Thank you very much, dear colleagues, dear friends. I am very honored to give the lecture in this session that bears the name of one of the most outstanding pioneers in the field of innate error of immunities in Asia-Pacific and really in all the world, my dear friend, Professor Yulan Lo. I also want to thank the boards of Malaysian Society and APSIT for this invitation, and particularly Professor Bahruddin ibn Abdullah and Professor Antan Hakima Ismail. In the picture, you can see the Casablanca Children's Hospital where I work. Dear colleagues, I believe that we can agree on these two main objectives for the fields of PIDs. The reduction of mortality from infectious disease, severe infectious disease. Indeed, PIDs can be considered today as the new conception of infectiology, or at least the explanation of severe forms of infections. The second objective is currently well established, is that the discoveries of the molecular mechanism of PIDs have an essential contribution to understand the human immune system. And to achieve these two objectives, we must improve the quality of life of our patients. First, by diagnosing as many of them as possible and treating them correctly. This will allow us to better understand PIDs in our region. Unfortunately, history and the current care level in our countries shows that there are enormous difficulties in the diagnosis and treatment of PIDs, and that the speed of development of our field in our region is too slow. So what should be done? We must contribute to a real revolution in our field. How to do that? By moving quickly to genetic diagnosis and gene therapy. I will give a proposal for in the end of my lecture. And to encourage the local and regional production of immunoglobulin. Who should campaign for the success of this revolution? It is the civil society, and particularly PID patient organization, and health professional must strengthen their support for the civil society by helping to raise awareness among the population and among the decision makers. But the most important thing is to involve PID patient organization in all our actions. For example, pneumonia is the single largest infectious cause of death in children, particularly between age 1 and 5, and particularly in South Asia and Sub-Saharan Africa. Indeed, PIDs described we believe that unrecognized PIDs are a significant cause of death from pneumonia in children. Early identification and adequate treatment of PID will reduce these deaths. Also, by describing describing PIDs in Africa, Asia, Pacific, and Latin America, we will better understand the immune system in all Homo sapiens. Indeed, the PID described in Europe and North Africa are genetic abnormalities that occurs in a small group of human Homo sapiens who left Africa 100,000 years ago. And 90% of the genome diversity of Homo sapiens remains in Africa. And there is so much to know about immune system in Homo sapiens in this region. In Asia, the founder effect of PIDs have certainly occurred after that. The plan for this presentation is, in the first part, I will speak about emerging countries and give an idea about history of PID in our region. The second part will be reserved to the current situation of PID in our regions, and I'll try to give some prospects to boost the field in our regions. These pictures from World Bank shows that a lot of countries from our regions have low income, lower middle income, or at least upper middle income only. Now about the history. This is the most beautiful picture I had with my friend, Professor Yulan Lo. It was at the end of the 6th Aziz Congress in Senegal, 2019. On the first row from the right, you can see Professor Yulan Lo, me, Elizabeth Miyet, and Leila Jdan, who is now the president of African Society for Primary Immunodeficiency. The second row, Nadia from Tunisia, Brahim from Algeria, Yusra, Rida Berbouche from Tunisia, our past president Nahla Arwa from Sudan, and our past president Tandakha from Senegal. 10 years earlier in Johannesburg, we formed a group for the development of PIDs in countries with limited resources. And from the right, we can see Yulan Lo, Brian Eli, Al Ghunaim, Antonio Condino, Monica Esser, me, Shenin Jan from Casanova team, and Rida Berbouche. The historical data was basically taken from two documents, from Aziz and Lazid, from this excellent book on history of primary immunodeficiency, and for Absid, the data was taken from the publication by the Indian team of Professor Surjit Singh. About African PID Society, David Beatty from South Africa in 1967 published the first series, and Abdullah bin Sliman in Morocco set up the first PID exploration lab, excuse me, in 1987. And in 1998, Mohamed Bjawi, Kosaid Allergy from Pasteur Institute from Tunisia, and Mohamed Rida Berbouche constituted the first group of PIDs in Tunisia. And in 1997, they published the the first Tunisian registry with 152 cases. In Morocco, in the same date, was created the first PID unit in the Children Casablanca Hospital. In 2000, the Moroccan PID Passion organization was created before the Scientific Society, and in Egypt, Aisha Al-Marsafi created the PID unit. In 2008, in Casablanca, was created the first, was held the first Aziz Congress, and the Moroccan PID Society was created. And in 2010, Moroccan founder effect of Achilles deficiency was published from a Moroccan team, and in the same date, the first BMT for SCID was performed in Casablanca. In 2011, the North African registry was published with data from Morocco, Tunisia, and Egypt. In 2015, was the first Congress of Arab PID Society, and after that, a lot of development was made in Tunisia, Morocco, Egypt, South Africa, and then Algeria, Sudan, and Kenya. Biannual congresses were organized in Morocco, Tunisia, South Africa, Algeria, Zambia, and Sudan. And as it developed a specific training, a project, which is one day in one country with one African expert. These pictures are from the first Aziz Congress in Casablanca, 2008. In the center here, you can see Professor Claude Griselli, who was born in Morocco and is still the honorary president of Aziz. On the right here, the first board of Aziz. From the left, Fatima Eilal, Morocco, Rida Berbush, Monica Esser, Bjawi, Mohamed Rashida, Bukhari, Abdullahi, Brian Illi, Iselmo, Mauritania, Nizar Mahlawi, and Amadou Tianouan. Below here in the opening ceremony with Claude Griselli and Professor Jean-Laurent Casanova. A real highlight, it was the Hajar Association for Helping Patients with PID that organized the first Aziz Congress. Here in the left, Madam Bushra bin Hayoun, General Secretary of Hajar, and in the right, Hajar, who is the first girl diagnosed with SCID in Morocco. She is now watching us from the sky. Ayub in the left, the first bone marrow allograft in Morocco, and from his brother here in the right. These pictures are from the first Aziz school in Senegal in 2009, and this beautiful girl is asking, is there any PID in Africa? Here are some posters from the Congress and schools, Casablanca, Tunisia, Sun City in South Africa, Algeria, Zambia, Dakar, and South and Sudan. This picture shows the delegates, African delegates in IP Congress 2003 in Portugal, where the APE project was discussed as a training program for Aziz. And in the right, pictures from 8 projects in Kenya, Benin, and in the Gabon. Maroufou Alou here conducted the first A project in Benin. About Asia Pacific, you know better than me. the history, but we can say that in Japan and China, efforts was made since 15th and 16th by the pioneers and the first reports and cases. And in Japan in 2011 were published 1,240 patients from Japan, and in 2017 was created the Japanese Society for Immunodeficiency and Autoinflammatory Diseases. In China, a lot of work and networks was done, especially by the Hong Kong team and Yulang Lu, especially good collaboration created with consultations and molecular exploration in iron from the 1977 Abdul Hassan Farhoudi created the first clinical immunology and allergy center. And yeah, and a lot of good work has been done. And in 2011, particularly by the Indian Society for PID in Malaysia, good work is really done now as this wonderful Congress. And in Turkey, a division of pediatric immunology was created in 1972, and a lot of good job was made. This picture from Malaysian Passion Organization for Primary Immunodeficiency. Wonderful picture from Indian Society for Primary Immunodeficiencies. A lot of pictures about schools and congress from Asian Network, and good job was made in networks and Asian collaboration, especially by teams from Hong Kong. Here in the pictures, Muhammad Ali Maliki, Abul Hassan Farhoudi, Asghar Mohammadi was the pioneer of the field. In Latin America, Charles Natspeeds from Sao Paulo and Renato Berron from Mexico created a group, and the group was presided by Ricardo Sorensen, and the group included 14 countries and became LAZID society, a society which organized the biannual congress, and in Mexico City in 2011, Santiago in Chile 2013, Argentina 2015, Sao Paulo in Brazil 2017, and in Mexico 2019, and several excuse me, specialist center was created in Brasilia, Argentina, Colombia, Chile, and Mexico, and Costa Rica, and most other countries. The registry of Latin America countries, American countries, was made by the software offered by European Society, and a lot of good publication of the registry was made in 1998 and 2007. And now the newborn screening is initiated in some countries. Here are the pioneers: Renato Berron, Charles Naspers, Ricardo Sorensen, and Antonio Candino. Let us move to the second part with the current epidemiology in our region. The main data was taken from this wonderful paper by Hassan Abul Hassani and Asghar Agha Mohammadi, and a lot of experts from the world, from which I take this picture. This map shows the prevalence of PIDs in different countries around the world. We see that paradoxically, countries with high population density, such as China, India, Indonesia, Brasilia, have low prevalence of PIDs. Of course, this is due to difficulties to access to care and diagnostic capabilities. This paper is one of the few ones that gave an idea of the prevalence of PID. The minimum prevalence in this study is approximately 29.1 per 100,000 inhabitants. The prevalence will be low compared to the current reality because these data date back to 2007, when the number of PID was very limited, and before the discovery to the predisposition of scourges public health as predisposition to tuberculosis and herpes. Also, the prevalence doesn't take into account consanguinity, which is very high in several regions of Asia and Africa. Here, the red columns gave the estimate number of PIDs taking into account the prevalence of 29 per 100,000 inhabitants. That's in Asia, we should have more than 1,300,000 patients, while the registry show only 16,000 patients. Also in Africa, the estimate number of PID is about 400,000, while registry shows about less than 5,000 patients. We can also give an idea of the coverage of these registries. This is shown by the green columns here, with a coverage of 33% in the North America, okay, and less than 2% in Asia and in Africa. This picture shows the percentage of consanguineous marriage in this part. I will give some idea about level of PID testings, and we'll use this nice paper from Yulong team, and excuse me, and this data, I will give only data on about APSID, and in this paper, the results given in this paper are taken from 427 works presented between 2015 and 2020 during the first 5 APSID schools to determine care and training needs. Let's start with diagnosis. This table shows the code proposed by Unanglu team. It is particularly interesting for its simplicity. It will allow us to compare Asian countries. And this histogram shows the level of test, that the level of test varies from 1 to 2 in low human development index countries here as Bangladesh, Cambodia, and about 3.5 for India and Malaysia, and more than 4 point for some countries and region as Japan and Hong Kong. This studies shows also that the main testing level positively correlates with high HDI index. This picture shows the countries by Human Development Index in 2022. This histogram shows that countries with low HDI, with low, medium, it's really low, and medium HDI, said at Cambodia, don't have essential immunologic testing. Okay, and genetic testing is lacking in a few high HDI countries like Indonesia and Malaysia, and in very high HDI, the genetic testing are available. And now what about the level of PID treatment? The data was taken from the Yulanglu team paper and also from Asghar Mohammadi from Journal of Clinical Immunology. And this table shows diagnosis and therapeutic researches according to HDI. Countries with low HDI, have only antimicrobial and immunoglobulin, IV immunoglobulin, and maybe not for all patients. And countries with very high HDI have newborn screening and even gene therapy, as you see here. In this map shows the availability of registries in red, access to bone marrow transplantation in yellow, and genetic testing in blue. The access of these resources is certainly not easy for the entire population, and several countries don't have them. This picture shows that countries like Afghanistan and Pakistan which have a high disability adjusted life year, here, for example, Pakistan and Afghanistan, there is a very low prevalence of PIDs. And the countries with low daily often have a high prevalence of PIDs. For example, here, Turkey, Kuwait, Iran, Tunisia, and Tunisia. But the prevalence doesn't seem very correlated to socioeconomic level, but seems more correlated to the level, to the development of medicine in the country. As you see here in Libya, Egypt, and Emirate, for example, the prevalence is still very low, very low. And now let us move to the third part. And as I present in the introduction, the development of the field in the low and middle income countries, the most countries in our regions, in AZ, LISID, and APSID, the development is very slow, and a real revolution must be done by moving quickly to the genetics and in diagnostic and therapy and production, immunoglobulin production. Citizens of AZID, LAZID, and APSID, the countries must unite their effort to constitute centers and networks which allow them not to invest in immunological exploration and classic BMT. A rapid transition to genetic testing therapy is urgently needed. In these countries with limited resources, civil society, and particularly whole the civil society, not only patient organizations, but also governments must understand that PID are currently the new concept of severe infectious disease, and the establishment of newborn screening and the improvement of their diagnostic and treatment will improve the quality of life of patients infected and will reduce mortality from infections. Dear colleagues and friends, allow me to end this presentation with the survey of possibility of gene therapy in Africa, which I presented at the IPIC 2019 in Madrid. In fact, the idea was present in 2008 during the first AZID Congress, when we asked Bobby Gaspar to tell us if it is time for Africa to switch to gene therapy. But the question, how a low-income country or middle-income country, middle human development index country can move to gene therapy. This is possible. This is possible by subcontracting the transfection of hematopoietic stem cells in countries with very high HDE or very development countries. And after the goal is to transform the allograft into an autograft in the country of the patients. We can do this autograft, this gene therapy, without sending the patient to very developed countries. The methodology used in this survey is based on six questions related to transplant facility and post-therapy cares. We had answers from 17 countries, and the main question asked are, is there availability for transplant, facility for transplant, all the transplant, not only bone marrow transplantation, and the possibility of autologous transplant like BMT, what is the level of laboratory to transduce hematopoietic stem cells, and what about arrangement to ship harvested cells, and well, is there possibility for clinical monitoring tests, and what about plasma cell preparation and storage in liquid nitrogen? What about a vector copy number by analysis by quantitative PCR and transgene integration sites? We were surprised by encouraging responses. Indeed, the possibility of transplantation were real in half of the countries, even they don't do the transplantation. But the possibilities are real, and they can do this, it. Also, referral of hematopoietic stem cell was possible in half of countries, and post-transplant care was available in almost 80% of the countries. This is a picture from Tunisia BMT Center, here with Fathi Mallouli and Mohamed Bjawi. This BMT room is called Casablanca, and really Tunisia is a leading country in BMT, and we think it can be a regional center for gene therapy. A great effort is also made in Morocco and in South Africa. What can I say in conclusion? I think the development of PIDs in our region is urgently needed to reduce mortality and morbidity from infectious diseases, and for better knowledge of the human systems of Homo sapiens. We must improve quality of life of our patients. But as I said, the development of the field is very, very slow, and we should make a revolution by moving quickly to genetic in diagnostic and therapy and immunoglobulin production. The most important thing is to involve civil society and PID patient organization. And thank you very much.